All right. All right, guys, so we might get a little wriggle on. Is everyone able to hear me? Where there's no issues. Beautiful. Okay, cool. So thank you so much for joining us today for our AHCWA Bites. We're looking at getting this one back up and running a bit more regularly. So we've got the wonderful Kate Rowland-Robertson today. She's going to be running through Gillick competence. And if you've ever had the pleasure to see Kate speak in the past, she's definitely one not to miss. So we'll just start just with a little acknowledgement. So, I'd just like to acknowledge that we're meeting here in Wooloo today at the AHCWA offices, and I'd just like to acknowledge that the traditional owners and custodians of the country, and pay my respects to the Whadjuk people of the Noongar Nation on which we gather today, and their deep connection to lands, waterways and communities. And I'd like to extend that respect to elders past and present and emerging, as well as people in the room today. So we'll stop sharing that one and we'll move on to Kate.
Yes, sure.
And take it away.
Let me just find the right document, and we should be good to go. Here we go. Can we all see that? We're all good. Excellent. Thank you so much for that welcome there. I just noticed I haven't updated the date on this. I've been giving this talk for a little while now. So thank you so much for joining me today. I'm Kate Rowland-Robertson. In my day job, I am a medico-legal advisor. And I sort of look at a lot of these sort of healthcare issues around, medico-legally, that intersection between healthcare and the law. So today we're going to talk about consent in the mature minor, which is an issue I'm sure many of you run into. So some of the main points we're going to look at today, we'll be looking at age of consent, Gillick competence, so that's the legalese term for consent in the mature minor. We're going to talk about assessing a minor for maturity, some of those competing considerations when providing healthcare. I'm going to talk predominantly to privacy today. I do sometimes talk on child rights as well, but that is when we've probably got a bit more time. So we'll look at consent to healthcare treatment, and the one that predominantly tends to pop up around mature minors being sexuality and sexual health, particularly in the primary healthcare space. We're going to look at the law and when it says it's child sexual abuse. So I am going to discuss a little bit around child sexual abuse at the end of this presentation. And then also about when do we need to tell people, when have we got a mature minor in our care, and who do we talk to about this and who do I tell? So what I tend to talk about with these sorts of areas and Gillick competence, and particularly the mature minor, it's a very grey area. And sometimes there is not a clear answer. And what I'm really hoping today is to run through some of the competing factors for consent to mature minors. And just so that when you're making decisions about mature minor care, about whether you can provide healthcare, when you need to tell somebody if something's going on, if you suspect someone's at risk of abuse, what does that mean? But it can be very, very challenging. And sometimes there's no right answer. You're looking for the best answer. For some people, providing healthcare to Gillick competent minors can be morally challenging. So I really encourage people to reflect on their own values when providing healthcare. I find with Gillick competence, there's some people who might say, yeah, but I'm a parent, and if that was my child, I'd really want to know this, or I'd want to be involved. Or when I was a mature minor, or when I was a minor, I really would have wanted my parents or my guardians involved in my care. So it's really important to sort of reflect upon those values and what that might mean if you're delivering care to mature minors. And the main point I always like to make, particularly around these sort of areas of law, is if you're ever uncertain, do seek advice on these matters. I say sometimes they're not straightforward, sometimes they're really, really grey, and it's really good to talk to people about these factors. So First of all, we've got to talk about the age of consent because that's a really important point when we're talking about healthcare. So the age of majority, which is the technical, again, legalese term for age of consent in WA, is 18 years of age. So if you're under 18, you are considered to be a child or a minor. Now, the big one is about sexual consent. So in Western Australia, age of sexual consent happens to be 16 years of age. But you'll note there that I've asterisked that. And we sort of got to ask, well, why is this asterisk and what does this actually mean? So there are provisions in West Australian law for minors engaging in sexual activity between 13 and 16 years of age. So the law recognises there are times when people under the age of 16 are going to be engaging in age-appropriate sexual activity. So in terms of this, what does it mean? So it extends to individuals when there's no more than a 3-year age gap between the youngest person and the oldest person in the partnership, then 13 to 16 years old. Now, I don't have my notes in front of me, and I'm just recognising now that it would have been helpful if I did so I could explain it a bit better, but I'll try and keep on track. So essentially, if you have someone who's 14 years and 6 months of age, and they're engaging in sexual activity with someone, for example, who is 17 years of age, that would be considered to be age appropriate because there's only 2.5 years between 2.5 years. I haven't got that quite right. My addition and multiplication is a bit nuts at the moment. It's never been great. But there's no more than 3 years older than those individuals. But say if you've got someone who's 13 years and 6 months and they're engaging in a sexual relationship with someone who's 18 years of age, that would not be considered age appropriate, and the 18-year-old would be engaging in child sexual abuse. So if you're having sexual activity with anyone under the age of 13, or not you, if an individual is having sexual activity with anyone under the age of 13, it is automatically an offence. There is no provision in WA law for sexual activity with anyone under the age of 13. There's also provision in WA law in terms of people in authority. So people in authority are anyone who's considered to be, for example, it'd be doctors, it'd be nurses, teachers, coaches, parents, anyone who's in that sort of workspace where they can, or not even workspace, priests, for example. If you're engaging with young people, if you engage in sexual activity with a minor aged 16 to 18 years, so anyone under the age of 18, it is considered to be a sexual offence. There is special protection for all individuals in terms of people in authority. So that's where we see individuals such as Grace Tame. She was sexually abused by a teacher up until the age of 18 years. So just because you've turned 16, it doesn't mean that it's automatically consensual. If that person is in a position of authority, it is still considered to be child sexual abuse. So when we're talking about informed consent in healthcare, so I do a quick refresher on this. So basically, informed consent is an individual's decision to agree to healthcare. And so in order for them to be able to provide that consent, they need to have accurate and relevant information about the treatment that they're seeking, and that has to include any alternatives to that potential treatment. They need to have an adequate knowledge and understanding of the risks and the material benefits of the treatment. They don't have to address every single potential thing that goes wrong. There is a recognition in law that you cannot possibly do that, but you need to ensure that you address everything that would be important to that individual. Informed consent must be freely and voluntarily given. It cannot be coerced. It cannot be pressured. It has to be voluntary. And the consent also has to be valid and appropriately timed. Now, interestingly, if you consent to healthcare, that consent remains in place until you withdraw it. But it's also got to be appropriately timed as well. So we do have to think about if someone consents to a particular procedure, while that consent remains in place, if it's 5 years later, things might have changed. So you might want to go and revisit that and ensure that that person still consents. So we're going to be talking about Gillick competence and what that specifically is. So it's really quite interesting. So it's a legalese term, sort of mature minor, or it might be used more commonly. So it actually came about in 1984. This is a UK case. Some of you may be familiar with this case. So what essentially happened is a woman named Victoria Gillick, she had, I believe, 5 daughters. And she found out that one of her daughters was seeking advice about contraception from a doctor. And I believe that daughter might have been 15 years old. And she was very upset about this. And so Victoria Gillick decided this infringed upon her parental rights to guide her children morally how she felt fit. And she actually took the local health authority to court to have it found that she had parental rights. But the court actually found that that Victoria Gillick didn't have parental rights in this regard. And actually, as long as children were properly informed and able to consent to healthcare, they had the right to seek healthcare without parental consent. So that case was dismissed. And I think a really important point that was brought out of this particular case is this quote from one of the lords, and I can't remember their name right now. But essentially they said whether or not a child is capable of giving the necessary consent will depend on the child's maturity and understanding and the nature of the consent required. The child must be capable of making a reasonable assessment of the advantages and disadvantages of the treatment proposed. So if the consent, if given, can be properly and fairly described as true consent. So if that minor has the same capabilities to consent to healthcare as an adult would, and as children get older, they do, as you mature, you start to develop those capabilities, they can consent to that healthcare. So it was found that mature minors can consent to healthcare without parental consent or guardian consent. Personally, I just really like that they named it after Victoria Gillick, and that's why we call it Gillick competence. So it was found that her daughter did indeed have the right to seek healthcare from a doctor without her mother's consent. So how can a mature minor consent? How do we assess this? You've got a young person in front of you and you're trying to work out can this person consent? So first of all, the young person needs to understand the nature, the consequences and alternatives of a proposed treatment. And most importantly, they have to be able to retain this information. They have to be able to use the information to weigh up their decision, and they have to be able to communicate their decision. They're really important factors. So what you will find with mature minor consent, and this could be used for any age group, and depending upon the nature of the treatment that's being proposed and the age of the young person, will depend upon whether they can consent to it or not. So for example, if you had quite a young person in your care, say you had an 8-year-old child and their parents weren't present and you needed to take their temperature with an ear thermometer. It is likely that an 8-year-old, you would be able to explain to them why they're having their temperature taken. It could be that they have an infection or they have a fever, or you need to check if they're at risk of an infection or a fever. You'd be able to explain to them that, you're going to put the ear thermometer in their ear and what that means. It's a non-invasive procedure. It's not required of them to, there's not going to be any big changes to the child. There's no permanency to that decision. And they should be able to understand that, that you don't necessarily need to touch them, or you may need to pull their ear up so you can use the thermometer. So that child could likely consent to you taking their temperature with an ear thermometer. That would change with the bigger the intervention. So if that 8-year-old was due to have surgery and the parents weren't around to complete the consent form, it is extremely unlikely that 8-year-old is going to be able to consent to surgery, and I'd argue that they can't. However, if that child was now 16 and potentially having a minor procedure or something non-permanent surgical treatment, there is a chance they could consent to that. And as long as they understand the treatment, the consequences, the alternatives, retain that information, can use that information to weigh their decision. Importantly, it doesn't have to be a good decision. They just have to be able to demonstrate how they came to that decision. They have the right to make a bad decision, and they have to be able to communicate that decision. So the smaller the intervention and the older the child, the more likely they are Gillick competent. So I'll run through this example. I've used immunisations because I feel this is usually a pretty good example as to how you can demonstrate Gillick competence. So we're going to talk about Oliver. Oliver has come in. He's made an appointment to see you, and you're the nurse at a local GP clinic. And Oliver attends his scheduled appointment with a form from his high school. Oliver explains to you that he's going on a school camp later in the year, but to attend the camp, he must be up to date with his vaccines. Upon asking his parents for his vaccination record, Oliver discovers his parents never had him vaccinated as a child as they did not believe in vaccines. Now, Oliver desperately wants to go on the school camp and he asks you if he can receive his vaccines as his parents will not consent, which means he cannot go on the school camp. Oliver tells you that he's applied for and received his own Medicare card and can pay for the appointment with his own money earned at a part-time job. So when we're starting out with Oliver here, there are definitely some signs that he is Gillick competent. So first of all, he's made an appointment to see you. He's attended that appointment on time. He's applied for and received his own Medicare card. And I would argue that anyone who can navigate the Medicare website definitely has a degree of maturity because I certainly struggle at times. Yeah, he can pay for the appointment. He recognises the appointment may cost him money that day. He's got a part-time job. So at the moment, we're thinking Oliver at 15 years old, he's quite mature. So you review Oliver's form from school, and that asks all school camp attendees to be up to date with their childhood vaccines. I apologise if you can hear my dog barking downstairs. He sounds very excited, so forgive the interruption if you can hear that. So while you're assessing Oliver, he asks if he really needs to be worried about the diseases listed on the form because he hasn't even heard of some of them. So you take this opportunity to educate Oliver about the diseases that childhood vaccines offer protection against and how those vaccines work. You explain to Oliver that he'd need to attend several appointments over a period of time to develop a catch-up schedule, but he has attended the clinic well in advance of his school camp. So it is actually possible to have him fully vaccinated prior to school camp. You advise Oliver on the risks and the benefits of vaccines. You talk about the side effects and risk of anaphylaxis. And Oliver asks you questions about the side effects and the likelihood of anaphylaxis. And Oliver notes that, look, if he has an anaphylactic response, his parents would likely find out he's had vaccines. But upon learning about vaccines, Oliver's now worried about being vulnerable to disease and he would like to be protected, even if he can't go to the school camp. And Oliver tells you he'd really like to receive his vaccine catch-up schedule that day. So going through this particular version of Oliver, we can say he is Gillick competent. In this particular situation, you've explained information to him. Oliver has taken that information on board. He's retaining the information. He's weighing up the risks and the benefits. You've explained to him the alternatives, which is to not receive a vaccine and that, he may be at risk of disease. He's asking appropriate questions. And Oliver's also recognising that, my parents will likely find out if he has anaphylaxis because he would have to go to hospital. But he's also understanding that he is vulnerable to disease and he would like to be protected. And so in this particular scenario, you can be very comfortable that Oliver is Gillick competent. In this situation, he's retained the information, he's weighed up that information, and he's communicated his decision to you. So you can say that Oliver is Gillick competent. Now we're going to have Oliver version 2. So Oliver is an alternative. So in Oliver version 2, you review his form from school, and this asks all school camp attendees to be up to date with their childhood vaccinations. While doing this, Oliver tells you how unhappy he is his parents won't let him be vaccinated as he really wants to hang out with his friends at school camp. You explain to Oliver that vaccines come with risks and benefits, which are important for him to understand. Oliver tells you that all he sees here are benefits, especially the look on his parents' faces when he shows them the vaccination record, and he laughs they're going to be salty. Oliver thinks he might get a friend to film the reaction so he can put it on TikTok, which in his opinion is a great benefit because he's going to get lots of views. This Oliver is clearly not Gillick competent. He's not listening to the information you're providing. He's not retaining the information. He's a bit excited about his TikTok video. He's not using the information to weigh up a decision, and he's not actually communicated a decision to you at all. So this Oliver is not Gillick competent. Now, these are pretty clear examples, and it's not always this clear as to whether someone is Gillick competent or not. So it can be that really grey area as to whether you can proceed or not. But these are examples of what Gillick competence and non-Gillick competence may look like. So one of the other big concerns we often see with Gillick competence is concerns about privacy and confidentiality. And the question may pop up, for example, well, can I go ahead and provide this treatment? Uh, is it okay? Do I have to tell the parents? Do I have to tell the parents or guardians, their child has attended today? Do I have to tell them about the care that has been provided to them? Or can I hold that confidentially? So the important part here is to think about privacy and the Privacy Act and the Australian privacy principles. Now, if you don't know about the Australian privacy principles, I really encourage you to look them up. They guide a lot of what we do in healthcare. There is like a summary guide which provides general information about the principles and what they all mean. It's really good to look at just to even be aware of them. So when we're talking about Gillick competence, the two privacy principles that we're really concerned about are principles 1 and 6. So we've got the open and transparent management of personal information, and we've also got the use or disclosure of personal information. So basically, anyone who accesses a health service, they must be able to consent to the use or disclosure of personal and sensitive information. And I'll talk a little bit about the differences between personal information and sensitive information. So personal information is information about an identified individual or an individual who's reasonably identifiable. So that means demographic information. It'll be a person's name, their date of birth, their Medicare number, their address. It'll be their gender, their sex. So that's information about them that can be used to identify that particular person. Sensitive information is anything that would be considered to be more harmful to that individual if it was released without their consent. So sensitive information will be their health information about sexuality, religion, political beliefs. We've just had an election. So if someone, thankfully in Australia, we do have democracy, but in some countries, obviously, your political beliefs can be used against you and used to harm you. It's very sensitive information. It could be information about a criminal history. So sensitive information is given a higher level protection under Australian law than personal information. So it's really useful to understand the differences between those, and I encourage you to look at the Australian privacy principles. So when we're talking about when can we release information about a young person when they've come in for healthcare? So we talk about two different situations with personal information and sensitive information. So when we're talking about personal information, there are permitted general situations when you can legally disclose the information. And that may be when you have a reasonable belief that it is necessary to disclose information or to lessen or prevent a serious threat to the life, health, or safety of any individual or to public health and safety. So if you have a reasonable belief or concerns that if you don't share that information about an individual, that they're at risk, if you've got that belief, you can, under privacy law, release that information. You can release the information if it is unreasonable and impractical to obtain an individual's consent. I skipped over that one there. So that may be, for example, you've had Oliver in. He had his vaccines, for example, and Oliver had a really unfortunate anaphylactic response to a vaccine, and Oliver is now unconscious. And you need to call an ambulance, and you need to tell the ambulance who Oliver is. It is unreasonable or impractical to get his consent at this point in time. He can't consent. He's unconscious. And you've also got the double situation there. The disclosure is necessary to prevent a serious threat to his life, health, and safety. The other time you may be able to release information is if there's a reason to suspect unlawful activity or misconduct of a serious nature. So in this situation, this may be reporting for child sexual abuse, for example, or just child abuse in general. Our laws for mandatory reporting in Western Australia are a bit different to the rest of the country. We're only mandated to report child sexual abuse. I think in every other state you have to report, any other kind of child abuse, including neglect, physical abuse, emotional abuse, etc. But it doesn't mean to say you can't voluntarily report. And in this situation, if you had a young person, a minor, come in and they've disclosed to you that they're being abused at home, and you believe they believe the abuse will be ongoing, you could choose under that clause to release their personal information to try and lessen, well, you're preventing a serious threat to the life, health and safety, but also it's misconduct of a serious nature. So you would be protected if you shared that information in good faith. Then we have permitted health situations. So this is when we're disclosing health information about an individual. So you again have limited provisions in law to release sensitive information or a young person's health information. And that will be in permitted health situations. So a permitted health situation can occur if the young person cannot physically or legally provide consent or is unable to communicate their consent. So if Oliver was unconscious after an anaphylactic response, he cannot physically or legally provide consent. So you could share his health information with the ambulance service. The disclosure is necessary to provide appropriate care or treatment of the individual. Again, you'd provide it, for example, to an ambulance service to ensure Oliver's appropriate care and treatment. And the disclosure is not contrary to any wish prior to the individual becoming unable to consent. So this is probably a bit trickier. So this might be if you've been looking after someone long term, you've had continuity of care, you've had a patient in your care for some time, and they've disclosed to you that their wish that they do not want their health information shared if they become unable to provide consent. So if you're aware that your patient has previously not consented to the release of their information, you must uphold that wish. You cannot share that information. I'm not too sure if that would be relevant in the care that you're providing. And I think in this particular situation, particularly with young people, this is probably a bit more relevant to the hospital system rather than primary care. Sorry, was there a question? I don't know, I heard something. Feel free to pop up again if you've got a question. So these are the situations, permitted health situations. Again, these are available in you can find these in the Australian Privacy Principles if you want a little bit of further information about that. But these are the situations when you can release that information. So when we're talking about consent to healthcare, in terms of Gillick competence, it's going to depend upon a healthcare treatment that's being proposed. So the more invasive or irreversible the healthcare intervention is, the less likely they're going to be able to consent. Now, with a Gillick competent minor, they can consent to healthcare. So if you've assessed a minor as being Gillick competent, you don't need to seek consent from their parent or guardian. It is irrelevant. They're consenting to their healthcare. So that's one thing I find interesting is occasionally I talk to people and they say, I think this young person can consent to their healthcare, but I've still got to get consent from their parent or guardian. That is absolutely not the case. As soon as someone's been determined as being Gillick competent, they can consent to healthcare. There is no other support required for that consent. Now, just because a Gillick competent minor may may be able to consent to their own healthcare, it doesn't necessarily mean to say they won't choose to be supported by their parents or guardians. They can absolutely have their parents or guardians involved in their healthcare. They may still want that, but they just want to make their own decision about their healthcare. And if they're Gillick competent, they can make that decision. The wishes of their parents are no longer relevant. So in terms of privacy law, and this is where it intersects with Gillick competence, as soon as a minor is Gillick competent or determined to be Gillick competent, they enjoy the protections of privacy law as if they were an adult. You cannot disclose that information without consent. And I think everyone's biggest concern when providing healthcare to a Gillick competent minor is they don't want to get that nasty phone call or that angry parent showing up in the clinic wanting to know, how dare you provide healthcare to my my child or my kin, I've got a right to know what's going on. You should have told me. You shouldn't be providing healthcare without my consent. That is absolutely not the case. As soon as a minor is Gillick competent, you cannot disclose any information about their healthcare without their consent. So even if parents ring and they say, I've got a right to know and you have to tell me, you cannot disclose that information because you don't have consent and you have to turn them away. Of course, if you get consent from the young person, that's fine. You can absolutely share that. But they enjoy the same protections under privacy law as a Gillick competent minor as an adult would. So it is recognised that some Gillick competent minors may still require family support after they've consented to healthcare. And even though they've autonomously sought that healthcare, it is just impractical sometimes to withhold information. Going back to that example of Oliver, where he's Gillick competent, Oliver recognised, my apologies again if you can hear my dog barking, he is very vocal. With Oliver in that situation, Oliver recognised that if he had an anaphylactic response to vaccines, his family were likely to be involved. It was just the nature of that healthcare. So it's really important that just because a Gillick competent minor can consent to healthcare and they may not wish to disclose that information to their parents or guardians, there are situations where it is impractical to uphold that wish. There is a case in the UK where this was found. It was a really sad case. It involved a 13-year-old girl and she was found to be 20 weeks pregnant. And it actually went to court as to whether she could consent to a termination of the pregnancy. And the court found that that she was Gillick competent and she was capable of consenting to having a termination. She did not require the consent of her parents or her guardians. But the court also empathised with her situation. I think she didn't want, it was a grandmother that was involved in her care. I don't think she had, up until that point, parents involved in her care. But the court recognised that while she was Gillick competent and while she was entitled to privacy and you know, she fell under privacy law, this is the UK, but their privacy provisions, it was impractical that just due to the nature of where she was at in her pregnancy, what a termination would mean at that stage and the follow-up care that she would need, it was pretty much impossible to actually keep that that information confidential. So there can occasionally be a conflict there that you just cannot get around, that while they may not consent to that information being shared, the ongoing practicality of the situation will require some sort of disclosure. That's in quite big situations. Again, as to whether that would be occurring in primary healthcare. I mean, maybe, you know, that particular one, you know, obviously it's a 13-year-old and trying to seek, you know, termination of a, you know, a late stage pregnancy. You know, you may see that in primary care, but, you know, often there'll be court involvement and that kind of thing at that stage, particularly when she wanted the right to be able to consent. So there are occasions where it is almost impossible to hold that confidentiality. And going back to, say, Oliver as the example, is that if he had an anaphylactic response, you'd need to call the next of kin because he'd be transferred to hospital. And as a 15-year-old, they'd be wondering where he is. So that's the grey we often talk about, that sometimes is not a great answer, and it's really important to seek support if you're having to make these decisions about a Gillick competent minor, because it can, from a legal perspective, get very tricky and very complex. So an important thing to note is that Gillick competence only covers consent to healthcare. It doesn't actually extend to refusal of health treatment. So if parents consent to treatment and the Gillick competent minor says, I don't want that treatment, that's irrelevant. The parent's consent actually overrides the Gillick competent minor's refusal. So in that particular situation, it may be, for example, if you've got a 12-year-old who is having their vaccines and they're needle phobic and they really, really don't want those vaccines and they're refusing to have them. The parent really, really wants them to have those vaccines. The parent's consent stands. These areas are likely to be more likely to be involved in hospital cases where it's about refusal of treatment because it's usually about life-saving treatment. It may be, for example, blood transfusions are the most common example. If you've got for example, a 16-year-old who, you know, is Jehovah's Witness and because of their religious beliefs wants to refuse a blood transfusion, that's likely to go to court for a decision. But in terms of their Gillick competence, they could be Gillick competent, but they can't use Gillick competence to refuse health treatment. I haven't included this today, but in terms of the other area where Gillick competence has different applications is in gender affirmation care. I've taken it out because there is so much movement in this space at the moment nationally. The advice is changing really rapidly, and there's been a lot of government intervention. So it's become a tricky area. We did have a few test cases over the years since about 2012 that have provided they did provide clarification in law. Then they became muddied again, but it's further just become confusing at the moment in terms of what's going on. So I've left that out. But just so you're aware, Gillick competence applies differently to gender affirmation care, and you'd need to seek advice from your supervisors if you've got a young person who's seeking gender affirmation care specifically. Doesn't mean to say they can't be Gillick competent to consent to other types of healthcare, but in terms of gender affirmation, it does have a different application. So it's just for your awareness, just because I know we're short on time. So in terms of sexual health, Gillick competent minors can autonomously and confidentially seek sexual health treatment and advice without parental knowledge or consent. And that extends to all areas of sexual health. There is no difference whether it's normal healthcare or sexual healthcare. That can be STI screening, it can be pregnancy testing, pregnancy care, and it includes termination of pregnancy care as well. If they're Gillick competent, they can consent. So if a minor discloses consensual sexual activity, they have the same right to privacy as the same with any other health treatment. I know, I talk to practitioners occasionally and they get concerned. Then, often it's that sort of moral feeling, oh, if that was my child, I'd want to know. Or, that's a minor in an age-appropriate sexual relationship and the minor's 14. It may be uncomfortable for some people because they don't think it's appropriate for a 14-year-old to be having sex. But if they're Gillick competent and it's within the bounds of law, they have the right to privacy. So if you were to disclose that information, you would actually be in breach of the Privacy Act and could potentially risk a report to the OAIC. I don't think it would necessarily happen, but just so you're aware, it could potentially be viewed as a privacy breach. Now, if you're in doubt and you're not sure whether you can provide healthcare to a mature minor or even advice about their sexual health, there is something called the Fraser Guidelines. I don't have them here today, but I'd encourage you to look for them. They can be hard to find. I have had people look for them before and they've been in touch with me and I've been able to give them to them. It is a legal thing. It's not a healthcare thing. The Fraser Guidelines aren't specifically weirdly used in healthcare. I think they should be everywhere, to be honest. But they actually they were actually developed by Lord Fraser, who was involved in the Victoria Gillick case. And they came up with this set of guidelines to determine when it's appropriate to provide healthcare to a mature minor. And they are actually really, really useful. So if you're in that situation and you've got a young person in your care and you don't know what to do, if you Google the Fraser Guidelines, they will be able to help guide you in your decision making. And of course, always seek support. So the premise of the Fraser Guidelines is that, look, a young person should be talking to them using your clinical skill to say, hey, it'd be really good if you had your parents or guardians involved in your care. It's about trying to get them, giving them support. It's, they're making some big decisions. But if you cannot persuade the young person to involve their parents or guardians, again, that they understand the advice that's been given, and if you believe their health, and that's their physical or mental health, will suffer if they don't receive the treatment or advice, and you believe it's in the young person's best interests to receive that advice or that treatment without consent, and particularly, and this is in regards to sexual health, that if you don't provide this advice or treatment or care, the young person is very likely to commence or continue having sex with or without contraceptive treatment, then you should go ahead and provide that care. So I find them useful in that regard, where you're trying to assist this young person. You want them to have that support, but they're absolutely insistent. They don't want their parents or guardians involved as to whether you can proceed with that care. The Fraser Guidelines will help you. So I'm just touching on child sexual abuse and non-consensual and criminal sexual activity. It's really important to touch on this with mature minor consent because a lot of the care is about sexual health. With sexual activity, like with healthcare, consent must be freely and voluntarily given. Consent cannot be obtained by force, threat, intimidation, deceit, or any other fraudulent means. Telling a young person that, I will break up with you if you don't have sex with me, that is not free consent. The absence of no does not mean consent. A failure to physically resist sexual activity does not mean consent is given. It's really important. I think people are becoming more aware. I think the Me Too conversations have been really great in this space, that people are becoming more aware about what consent is and what it isn't. But young people may or may not be able to recognize this yet. Anyone under the age of 13 cannot consent to sexual activity. That is sexual abuse. And if they're 16 to 18-year-olds or anyone under the age of 18 cannot consent to sexual activity with a person of authority, that is also sexual abuse. So that's our doctors, nurses, teachers, care workers, coaches, priests, etc. So a person, that's what we've gone through, is a person with a child under their care, supervision or authority is considered to be a person of authority. So anyone under the age of 18, you cannot go, that child's now turned 16, they're able to consent. If that person is in authority, they cannot consent. There's an imbalance of power. That is sexual abuse. So what does the law require of you in terms of child sexual abuse? Child sexual abuse is a permitted general situation. You can disclose that personal information. It may be disclosed under privacy law. And in WA, you are required to provide a mandatory report. I talk about nurses there. If there's nurses in the rooms, mandatory reporting will extend to nurses, doctors, teachers, and a number of other professions. It's in the Act. It's really important, if you suspect a child is being sexually abused, to document everything and report that immediately to the mandatory reporting service. As long as you provide that report in good faith, you are covered. If you form a reasonable belief a child is being sexually abused and you disclose that information in good faith, you are protected from liability. So you cannot be found liable for disclosing that information without consent. The child no longer has a say as to whether that is being reported. So what's the main thing? What happens here? Seek support. You're not alone. These are really grey areas. It can be really difficult sometimes to determine if a child is Gillick competent. Speak to your coordinators, speak to your supervisors and your managers. There's a sexual health helpline. I think Sexual Health Quarters manages that. I can't remember off the top of my head, but you can give them a call. They're really helpful. If you're a nurse, there's a 24/7 ANF helpline if you're a member. Or you can use the EAP service sometimes if you've had these really difficult situations where you're talking about consent, and sometimes they're really tricky, and particularly if you're talking about child sexual abuse, it's really, really confronting. So do use your EAP service if it's available to you. Do talk to people around you. They're here to help you. So I think that's a very quick, brief overview of Gillick competence. There's some references there. I'd be very happy to talk about any questions anyone might have.
We've got Heidi has their hand up. Heidi, if you want to unmute your mic.
Hi there. Thank you for the great presentation. I'm just calling, I'm asking about the last one you were talking about, how to respond for disclosure.
Yes.
So I've noticed there's sort of some, obviously each service should have their sort of policies around this, but I've noticed that those policies vary greatly, and especially in the community controlled space, sometimes those policies are just pulled from, say, the Children's Hospital or somewhere else like that, and they're not very culturally safe.
Yeah.
And they often include calling the local police.
Oh, yeah.
So which I have noticed can be, especially in a really small community, that can be really unsafe for that young person.
Yeah.
So I'm wondering whether you have suggested policies, So I guess I've spent a bit of time having a look at those different policies over the years, and then trying to understand the follow-up. I work in SEWB and a domestic sexual violence service, of ways that our service can support. For example, rather than calling the police, if we can follow the child protection process, but then liaise and support that family through that. Potentially, if usually there's detectives involved, then we can help facilitate that engagement instead of sort of just including the local and then having, them calling the detectives, and the detectives kind of come up without discussing it. And everyone knows what the detective car looks like. It can be sort of it can extend the trauma.
Definitely.
For the individual in a way that I think their rights are removed sometimes. So do you have any suggested policies around that? Around like a culturally safe way to respond for AMSs?
Yeah, I personally don't have the policies to provide. I'm always happy to assist you with these things.
Sorry, I guess I meant, do you know of, somewhere?
What do I know of? Do I know of somewhere? Look, I think probably SARC would be a place to go. Sexual Assault Referral Service, I'd probably go there. Look, my general recommendation, I'm going to give you a very medico-legal viewpoint here. It's very cold and very removed. My recommendation in this space would be to follow the mandatory reporting process, which is to phone that mandatory reporting number. Then it's not your problem. And so what it becomes, to be blunt, you follow that process, because they need to assess that information to determine, because when you're making a report, remember, you're making a report in reasonable belief. Now, it's not your role to ascertain whether the abuse has taken place or not. Your role is that you've formed a reasonable belief, and you call that number because you need to determine, does it require further investigation, and allow the Department of Communities who oversight the mandatory reporting service to do their job. To go and ask the questions to start their investigation. And if it becomes that there's a criminal matter, they manage that.
I agree. The mandatory, but I find sometimes people feel like they want to make sure that maybe
their concerns are being taken seriously.
That there's a swift response, or that they're doing the right thing, or that so I guess
I think
they're doing both. I've seen
it's really challenging, and I think it's really hard when you're in these situations. They're very confronting, but I think again, I'm going to take the cold response, which is, and this is to protect everyone's interests really, is that, look, particularly if you've got immediate concerns about a child's safety, then the police might be appropriate. But you really have to weigh up those situations, and again, providing culturally appropriate care. But if you're concerned, if a child is going to go home and something really bad is going to happen to them, you need a different response, because that would be an immediate.
That's also a child response. There's also a child protection response to that as well.
Absolutely. Yeah. So, it's a different situation. But if we're talking about a child, for example, who's disclosed to you that they're being sexually abused, and you'd need to explore that situation a bit further. What does that mean? Is it happening at home? Is it happening at school? Is it happening when they go to have sports classes? Or when is it actually occurring, and what does that mean? Because they might not be in immediate danger. Yeah. So, the police response, is more about, if we've got someone who's in immediate danger, then, that's when you probably make more of a clinical decision as to when is it appropriate potentially to disclose that information. But overall, I'd encourage to use the mandatory reporting service. I think it's important to, I look at that more as a due process, that everyone's entitled to that due process. And of course, if you have immediate safety concerns, that's where you would probably escalate based upon those immediate concerns. If the child doesn't have anywhere safe to go, that's when you, again, looking at a more urgent response. But going through that mandatory reporting process, it allows due process to happen. It allows it to be investigated. It allows, the Department of Communities to then take that response. And then you're not responsible for coordinating that care. You're not responsible then for coordinating the detective, etc. That comes later if that's appropriate. But the mandatory reporting service needs to determine as to whether that's appropriate or not first. So my feelings would be to follow that process. I can't tell people what to do. So even in my day job, I don't tell people what to do. I advise them. So, you can only advise. And, my advice would be to follow that mandatory reporting process, unless, of course, you have immediate safety concerns for a child where, a stronger response is required.
My experience is when there is those immediate response required, then there is child protection steps in anyway. So it's not like the police step into that engagement. They call child protection anyway.
Yeah.
And then something is organised. So I don't have any. I think that's also, it's a good thing to do, to make that report urgently.
Yes,
and then
absolutely.
They can also assess. They're better at assessing the actual immediate.
Yeah.
Than because they're specialists in that area.
Absolutely.
And then they can or cannot engage the police as well. So
as required. Yeah.
Thank you. That's what I wanted to hear. Just
no problems. Good luck.
Thank you.
Beautiful. Thank you, Heidi. I reckon we've got Chanel down here as well. Guys, if you have any other questions that you don't feel comfortable saying out loud, you can pop them in the Q&A as well. And Janda will keep an eye on those. Janda's also going to pop in a little link just for an evaluation and pop a QR code up as well, just in the background here. But Chanel, do you want to have your question? Can't hear you there, Chanel. Just try and mute your mic there. Maybe not.
You could always type it in the chat if that helps.
That's all right.
My lip reading's not quite that good.
I don't know what's going on. We'll see.
That's okay. I can wait a moment. Maybe trying to dial in on somebody else's.
Beautiful. While we're waiting, I'll just share my.
Oh, there we go.
Oh, we're on. Okay.
I did come into my manager's office. What I'm wondering is, within the primary healthcare service, for those that come in and we deem them as a mature minor, pretend for a sexual health issue, is it for each issue that client presents for that we then cannot talk to the parents about that? Because sometimes the parents can still ring out, pretend it's a 13-year-old, 14-year-old, or whichever age we deem for the mature minor, but they can ring up and get their medical records for other issues. But is it all the medical issues, or what? Yeah, I'm trying to get my head around.
Yeah, no, I understand. No, yeah, absolutely. The answer is it depends. That great legalese answer. So you are absolutely correct to note that. So Gillick competence fluctuates. And it's always going to fluctuate. And so it's a matter of, it can be appropriate for, some interventions. So you might have a 13-year-old come in and, you assess them and you feel that they're Gillick competent to talk about contraception and to make some decisions there. And they may or may not be able to consent to certain interventions because they may be mature enough to consent to is sort of a shorter term contraceptive, but maybe not a longer term one, for example. Or, you go through the contraception thing, everything's great, you're fine. But now they've accidentally become pregnant anyway. And then there's a look of, it's a later stage pregnancy maybe. And then all of a sudden you're looking at different surgical options and, circumstances might have changed. So there is the potential they could consent to one component and then not to the other. So if a parent rings and then requests that child's records, then it's a matter of they can have the information where the child's not been deemed Gillick competent, but potentially the child's still, I'm going to take that back for a second. The child can still potentially consent to release of information because just because, for example, they're not competent to consent to the treatment, it doesn't mean they're not entitled to confidentiality. And so you can still hold that information confidential. And if you believe that child is competent to manage their own information, you wouldn't share that. It could also be, say, the child, as soon as a young person applies for and receives their own Medicare card, they're automatically covered under the Privacy Act as if they were an adult. So even though they might be 15, they might have got their own Medicare card, They may or may not be able to technically consent to all healthcare, but it doesn't mean their information can be shared. So confidentiality, Gillick competence can influence privacy, but it doesn't necessarily mean that just because they're not competent to consent to something, that the information should automatically be shared. I'd still be talking to that young person saying, hey, particularly if you've assessed them at some point and said, oh, look, they seem Gillick competent for this, that, the other. And look, it is really tricky. There's no yes or no answer. And, it's interesting because I hear people go, oh, what age does someone become Gillick competent? There is no age. It fluctuates. It's grey. There is no, you can't say, oh, they're 12, they're definitely Gillick competent. No, not necessarily. So there is no age set in law, but it's a matter of just because when they're starting to become somewhat Gillick competent, could probably consent to some things, maybe not consent to others. It doesn't mean to say that their confidentiality should necessarily be breached. And so it's going to depend. The older the child is and the more Gillick competent they are, the more likely you're going to hold their information as being confidential. But if you've had a young person come in and, they are, say, 13, they're not particularly mature, but you think it's in their best interest to have an STI test and, you deem them competent enough to have screening, it all comes back as negative, but they're really adamant they don't want their parents to know that they had that test. Then you may keep that information confidential if the parents were to request a record. I'd always recommend talk to people. But yeah, just because they're not Gillick competent doesn't necessarily mean they're not entitled to confidentiality, if that makes sense.
Thank you so much. Thank you for today's session.
No problems. Thank you.
Cheers.
Awesome. All right. Who else do we have? Just got a note on Alyssa.
I'm just having a look there. Is it important from a legal to note why you have deemed the minor as Gillick competent? The minor is always going to be Gillick competent for the same reason. They're going to be Gillick competent because they've had all the treatment information explained to them. They've retained that information. They've weighed that information and they've communicated a decision. And so that's the main thing. So they're only going to be Gillick competent because they can do that thing. If they can't do those things, then they're not Gillick competent. So I don't think you have to note why you've deemed them Gillick competent or what made you decide. It's because they've got all the information, they've retained it, weighed it, and communicated a decision. But I would recommend, particularly as they're younger and, on the younger spectrum, that you've assessed them as Gillick competent, it's good to note that, particularly if you've got, areas that, where people might be, in the courts or, there's concerns in their life or there's interesting things going on for them. It's really helpful from a medico-legal perspective to have that information documented in the record. It can protect you.
Got it. Thank you.
You're welcome.
All right, we've just got a couple more minutes. Is there any other burning questions before we finish up?
We're all happy. I'm always happy, Liberty, if you get questions, you want to email them through, I'm always happy to respond.
Amazing. Thank you so much, Kate. And thank you. You just have such a beautiful way of making such a grey area a bit more black and white. So thank you so much for coming on today. We really appreciate it.
Thank you for having me.
No worries. All right. Thanks, guys. If you've got any questions, send them through. Otherwise, I might look out the little QR code as well. Beautiful. All right. Everyone have a great day.
Thank you.
Thank you.